let's go through interpreting and presenting some chest X-rays. Again, I think that same fear that someone mentioned about, just missing something obvious is absolutely at the forefront of my mind every time I read a chest. And even, I've got to be honest, like every time a new exam, X-ray comes on, like it's not something I read. Like, what do we do with chest X-rays? Often it's looking for lines, and is our central line in the right spot? Maybe we've had some kind of hypoxemic event, and we take a chest X-ray, and maybe we're looking for a pneumothorax. We often have a report there if it's from a trauma situation or any other situation. So, we just don't read these without a report a lot of the time. So again, I think it's I think this can be very difficult, and we're trying to use a strategy to make this far more comfortable and safe for us to get through this exam with. So the aim and approach to assessing chest X-rays: identification of common abnormalities, practice describing chest X-ray findings in a succinct manner. And so, look, my disclosure is, so I've got a mate of mine who's who's one of the founders of Radiopedia, and literally before my exam, I went to him and said, "Hey, Andrew, can you teach me how to read investigations?" And so we just went through all of these things. And so even for this particular, great resource. So if you haven't already heard of it, Radiopedia is just amazing, and they've got lots of courses there. So you really, I don't know if I'd do it for this exam now, but if it's such a great resource, and if it's something that's a real sticking point, they'll have lots of basic stuff that's at our level as well. But essentially, what I went through with him was, what can I say? First of all, I'm going to clarify all the chest X-rays from the exams, just to make sure that we're reporting it correctly, and also just try to get his take on certain things to try to, this is a bit of a hack like the medical exam. We're trying to sound like someone we're not, but for the purpose of this exam that's in front of us, right? So that's what I'll try to communicate to you guys, and try to give you strategies that he's given me. So correlate the image presented with a patient history and clinical information. Again, really, really helps a lot of the time. If you see an obvious abnormality, you just have to mention it, because that could be all that is needed for you to move on. And imagine starting to say everything else in a systematic way. You may say things that aren't true because you're just not used to reading chest X-rays. So just go for the abnormality. It stops you saying lies or incorrect statements, which can lead you into problems later. If you find it difficult to identify pathology, then absolutely work through a structured approach, and also look for relevant negatives. I'd be looking for this. I'd be looking for that in this situation. I can't seem to see it. You can use words to show that you know what you're looking for, but you just don't have that expertise. And it might be, and I think that sounds a lot better. It goes a lot further than just not seeing anything, or potentially seeing the wrong thing. So we'll go through approach to chest X-rays, a few exam hacks as well. And yeah, as I've kind of mentioned in the pre-reading, approach to chest X-rays is pretty straightforward. After, I wouldn't necessarily be going into image quality and spending a lot of time on this, but if it films absolutely poorly presented, that's something to comment on. Rotation, inspiration, expiration, penetration, PA versus AP film really matters for the cardiac silhouette. But the general approach: airways, the breathing, which is the lungs and pleura; C is the cardiac silhouette; D is the diaphragm and the pleura; and E is everything else: bones, soft tissues, tubes, lungs, valves, pacemakers, and then review all areas. Now, I used to do this as airways, including lungs, and then B for bones, but often I'm looking at airway, breathing, circulation, cardiac stuff, and bones only if I'm concerned about trauma and rib fractures. So I think this is the geeky medics form of reading a chest X-ray, which I really like. So how do you assess the airway? Really assess position of trachea, follow the airway down, and assess the left and right main bronchus. Presence of any foreign bodies is pretty important in our context, and the presence of an endotracheal tube, and any kind of deviation as well. The ideal distance from the carina is, you're hopefully having about 3 to 5 centimeters of endotracheal tube distance from the carina. So there's just an example of an image, and you just trace it down, and showing that you can see both bronchi and assess for those things. How do you assess the lung fields? Again, one of the key words would be symmetry. As soon as you asymmetry, it's something to comment on because you're not really committing to something. You're saying, look, this looks asymmetrical. And for whatever reason, whether it's due to increase in or decrease in space, which means something, or there's increase of pacification or lucency, which means something else. So you check the lucency and density, check the lung borders, check the APC's upper and mid and lower zones. The more wider and dense the lungs are, the less gas. The darker lungs are, the more gas there is. And then check the high one as well. I like this kind of picture. I forget where I found this, but just being able to divide it up and look side to side is probably a way you can help to check whether there is symmetry or not. How do you assess for effusion? So assess the cospheric angle, see if there's any blunting. And just know you need quite a bit of fluid before any pleural effusion is present on an erect chest X-ray. And that's a classic example. You've got a bit of a meniscus forming there as well. So homogeneous opacification is known in the right lower zone with the opacity seen to track along the lateral chest wall. The right costa for any angles obliterated with a meniscus noted. Findings are suggestive of right-sided pleural effusion. Now, this is probably a bit more obviously a pleural effusion to everyone, but I like the way they've talked about it. If you're not certain what it is, you just say true statements with increasing specificity. This lung is abnormal. There is asymmetry. So those are the obvious things. There's a opacification in the right lower zone. That's true. You haven't committed to anything yet. I think I can see a meniscus edge. This could be pleural effusion or right-sided pleural effusion. So saying things with increasing specific specificity increases the ability for you to say more true things and less wrong things. Again, because we're not radiologists and we're trying to be as accurate in this game as possible. How do you assess the cardiac silhouette of mediastinum? So yeah, position of heart, third to the right, 2/3 to the left. Is there the presence of cardiomegaly? So it should be less than the 50% of the cardiothoracic ratio. And then look at all the cardiac borders. Is descending aorta visible? Left and right atrium. Assess the mediastinum. If it's greater than 8 centimeters, it's probably enlargement. And you can look at all the different aspects of it. And are there any obvious pathologies? So looking at the heart, I mean, literally what I'm doing here is I'm making sure that I can see all the edges and it's the size of it. And that pretty much covers me for most of the things I need to see. If there's any blurring of an edge, then you know that there's now an interface that the X-ray can't go through. So there may be consolidation at the lingular aspect or one of the lower zones, for example. Interesting to see that part there's the aortic trunk. Think about when that could be enlarged or displaced. This is the pulmonary trunk. Think about when that could be enlarged or displaced. And again, I'll bundle these into specific situations. So hopefully you can memorize them as a bundle to comment on. How do you assess for diaphragm and pleura? So assess the position of the hemidiaphragms, review pleural air fluid, review cospheric angles, look below the diaphragm for evidence of any free gas. If a pneumothorax is suspected, consider inspiratory and expiratory films because expiratory films will cause the pneumothorax to be more pronounced. And they may have the presence of a deep sulcus sign. So I thought I'd just give the example of a normal and then normal cospheric angles. And then here we have a deep sulcus sign and potentially associated with some fractures there. Deep sulcus sign on the left hemithorax, pneumothorax, so indicating the presence of a left pneumothorax. And then how do you assess everything else? Bones. So yeah, check the bony structures, trace each rib as you see it, clavicle, scapula, spine, sternum, alignment of spinous process, and assessment of vertebral bodies. Obviously, for a trauma situation where you've got the history of that patient absolutely in front of you in the viva stem or otherwise, then I'm absolutely checking the ribs because that's the most common thing really to fracture. But in any other situation, I will put that down lower in my list of things to check. What bony abnormality do you see? Does anyone want to comment on this one?
I can give it a go now.
Yeah, good.
Specifically for the bony abnormalities on the left side, they look to be like rib fractures. 4, 5, probably of like 5 and 6 or 6 and 7.
Yeah, 1, 2, 3, maybe that's 4. I think 5, 6. So yeah, you can see that if you trace it, there's a discontinuity. It just doesn't look the same as that side. So yeah, that's absolutely right. I was about to say, so every time you see rib fractures, automatically, what's the next thing you should check for or mention that you're checking for?
Just looking for pneumothorax. So yeah, lots of lung markings in the left side. If it's erect, then I'd expect it to be apical. But as you said, if you have supine, it might be a deep sulcus sign.
Yeah, sounds good. So we couldn't see any pneumothorax there, maybe pleural fluid collection, but these are relevant negatives to talk about. And again, you're trying to give it an impression of expertise in something maybe we're not that familiar with checking for, but at least you know what to look for. What is everything else? Lines, tubes, drains, devices. Great. Let's just go through lots of cases, get you guys familiar, and just practicing, talking out loud with these cases. So let's say you have an 80-year-old male with atrial fibrillation presenting with shortness of breath. Describe this chest X-ray. Hey, and before I even say it, hey, D, just because I've got you, without seeing anything, what would you expect to see on this chest X-ray that you might mention, or relevant negatives, relevant positives?
So I might expect to see a dilated left atrium or enlarged left atrium, which could be causing this atrial fibrillation. Maybe signs of heart failure, such as signs of acute pulmonary edema.
Mm-hmm. Anything else? And because you mentioned heart failure, what are the multiple things that you might find in chest X-ray in a heart failure patient?
Yes. So you might see upper lobe diversion of the vessels, perihilar, so like bat wings or and then pleural effusions or curly B lines, which would be like interstitial edema.
Great, and maybe some cardiomegaly as well. So, yeah, what do you make of this, B?
Yeah. So I think the most obvious abnormality for this is the increased lung markings, perihilar. And if I can convince myself there are some curly B lines as well, looks to be some pulmonary edema. Also note that the patient has a pacemaker, and it looks to be single lead.
Yeah, good. Yeah, good. So you're absolutely right. These horizontal, it's all lucency, really, isn't it? But these markings are going horizontally and not going necessarily outwards from the hilum. So these are some curly B lines, single lead pacemaker, cardiomegaly, prominent interstitial lines. There's some mild blunting of the left costophrenic angle. Absolutely. And diagnosis, yeah, so clinical picture is consistent with heart failure APO. Let's go with this one. Again, think about what you would expect to see in this patient, and then I'll get someone to comment on it. So again, because I want everyone to just practice talking out loud. That's part of the big part of these courses, just to get you talking. So everyone, take 30 seconds, just say what you see, and at the end of that, tell me your thoughts. I'll give you everyone 30 seconds. Hopefully everyone's had a go at saying true statements of what they see, and based on this clinical picture of what they might expect to see, but they don't. Liz, what are your thoughts?
So the major findings would be that this is a man who's had a sternotomy. I can't see any valve replacement though, and he's got a pacemaker, single lead. The main finding would be on the left side, there's some increased opacification, especially in the left mid-zone, and there appears to be almost a meniscus there, which could indicate a pleural effusion.
Excellent.
In the context of a man with Parkinson's disease, he may have had an aspiration event and may have a pneumonia.
That's good. That's really good. Bilateral pleural effusions, left greater than right. So I think it's really fair that that's far more obvious on the left, and it's a poor inspiratory film, really, so it's hard to tell. Lower lung, left lower airspace opacification noted adjacent to the pleural effusion. Heart really quite hard to tell. Intact median sternotomy wise, single lead pacemaker, prominence of interstitial markings, bilateral hilum, unremarkable cardiomediastinal silhouette is unremarkable in size and contour of the trachea's midline. That's good. So you got a lot of really useful things out there, and hopefully, again, just having this past history I mean, really helps us to go a lot of the way into saying true statements and potentially mentioning relevant negatives as well. So this is the exam hack. So, what features would you expect to see in each clinical scenario? Group these as a memory aid. And when you think, heart failure, think of this bundle of findings: cardiomegaly, interstitial fluid, pleural effusions, venous congestion. And you might think of which devices, if there's a device there, it'll be obviously mention it as well. 19-year-old male, fit and healthy, presented with shortness of breath, left-sided chest pain, no history of trauma. What's the abnormality? And so the next person along, just looking at that history, what do you expect to see on a chest X-ray?
I expect to see at least a left-sided pneumothorax, or
what else could it be?
It could be rib fracture. There's no trauma, so it's unlikely to be rib fractures. And other things, it could be some sort of silhouette sign in terms of pulmonary embolism. That will be more rare for a 19-year-old.
Yeah.
So
okay. Let's go with your. Well, tell me what you can see here. Then, actually, everyone, just have a go at describing this chest X-ray. Like, this should take 10 seconds. Hopefully, everyone's kind of had a look and seen something abnormal. And again, if this was the situation, young male having shortness of breath, chest pain, Jonathan, what do you see? Well, read this chest X-ray.
So the trachea is normal. So trachea is slightly deviated to the right side, which one would expect from a pneumothorax. And on the left side, I'm trying to look for the pneumothorax that would be, I think, in the upper lobe and the middle lobe. I can see that there's a bit of loss of lung markings that would be indicative of the apical pneumothorax on the left side.
So good. There's a thin left apical pneumothorax with pleural edge evident and no vascular markings peripheral to it. And again, I hope you're getting the sense that once you got the clinical picture, great, you can see that edge there. There's no edge present on that sign. It's asymmetrical. And the context means that I'm pretty safe in saying, look, this patient, I think there's a pneumothorax on the left apical side. I can see a lung marking edge here. That's the most prominent finding. Hopefully the examiner moves on. If not, hey, I'm going to go through everything in a systematic way, but everything else looks normal. So exam hack for young, shortness of breath. It's either pneumothorax or maybe pneumonia. They got short of breath, so maybe it's some kind of pneumonic process as well. Okay, 75-year-old male presenting with chest pain and palpitations. What device is this? Everyone have a think about it, and let me know if you can figure out what this is.
Yes, so this is severe cardiomegaly, and there is a 3 leads pacemaker and the prominent gastric bubble, and there's
and where are
there's a lung.
Where are the leads? What kind of pacemaker do you think this is?
So yeah, from the base, there are 3 leads coming out, but I can see only 2 leads is coming to that. So it's a biventricular pacing.
Yeah, fantastic. So this is a biventricular cardiac pacemaker instead of patient with heart failure to aid cardiac resynchronizations. And you've got a couple leads there, both in the ventricular area. It's such a massive heart. It just makes me get the sense that this is pretty severe heart failure. Because, even if this was a AP projection, it's still a massive heart. So it kind of makes me think, unlike the previous one, which was single lead, this might be a biventricular pacemaker, which has a lot of meaning to it, because this is like some level of end stage heart failure that needs resynchronization.
Hello, here. Just a quick question. Is there a lead in the right atrium as well?
Yeah, like this one seems to go there as well. I don't know too much about the detail of biventricular pacemakers though. if anyone wants to weigh in on that about where each of these leads needs to be, that'd be great. But
I would agree based on what I know about pacemakers, which is basically just through study for this exam. There looks like an atrial lead over on which has the most loosened part on the tip. Right over on the left-hand side of this image, the image, the point that you've got your mouse on there, I think is the right ventricle, and then there's two little bright spots over in the left ventricle. So it looks like it has 3 leads. And then if you look at the pacemaker box, there's 1, 2, 3 like leads that plug into the box where those connections are. I'll see if I can 1, 2, 3 little spots there, which led me to think that we've definitely got atrial and ventricular pacing.
Yeah. And which is safe to say biventricular pacers, it's fine that it has a 3rd lead there as well. 85-year-old female with a pacemaker. What do you see? What do you make of this? Everyone have a go at just talking out loud all the findings that they can see on this chest X-ray. And next person I'll go to. If anyone who's got their cameras off wants to be asked questions, just put an exclamation mark next to their name. And I'm happy to ask them as well, but otherwise I'll go back. So take 20 seconds. And what do you reckon?
Hi, can you hear me?
Yeah, all good.
Good. So this is an upright AP chest X-ray of a lady with a dual chamber pacemaker with right atrial and right ventricular leads. There's also a mass in the right apex, and the cardio mediastinal ratio is increased. She's got cardiomegaly.
Yeah, good. Now, interestingly, when we read the report on this, it was just a dual chamber pacemaker and the lungs were clear, but clearly there's asymmetry there. So I don't think I'd commit to the fact that there's a mass there, but I'd say there's asymmetry with increased lung markings or haziness up in the right upper zone. And that's probably how I'd talk about it. But yeah, everything else you said, you've got a pacemaker there, you've got even on an AP projection, this looks like an enlarged heart as well. Every time you see any kind of, instrumentation to the chest, is there anything else you'd want to look for?
I would look for, something that I just noticed that isn't an answer to your question, but I've also just noticed some fluid in the fissures. If it's a recently implanted device, then I'd be looking for pneumothorax and for effusions as well, in case there's been some bleeding.
Yeah, great.
And
so in the, again, I forget where I got this chest X-ray from. It talks about having a small apical pneumothorax. However, running it by my radiology mate, he said that, essentially you can't see a pneumothorax on this. But again, it's harder to see when it's just on a screen like this rather than with a high res image. But again, the main thing is to, I'm looking for you can see the pacemaker, you can see your relevant findings, and you're looking for any complications of pacemaker insertion. And even if you don't find one, even if you can't see one, it shows that you're looking for it. And I think that goes a long way to showing you have some level of expertise in this. So think of CVCs, Porticats, Vatscats, Hickmans, whatever they are around the chest, really just say that you're looking for a pneumothorax because it is very relevant to us. And I can just imagine that being pretty important in the exam. 40-year-old male, chronic heart failure. What do you see? What are the devices? So quite a few things going on here. So again, everyone else have a go at noting everything that they see. Yeah, that's probably about enough time. So what can you comment on?
Yeah, so there's a few things going on in this chest X-ray. So the most striking things that I can see here is that there's a patient that's had a previous stenotomy with sternotomy wise in situ. They have had a valve replacement by the looks of it. And looking at the positioning, may be wrong here, but I think that might be a mitral valve a replacement, or certainly an annuloplasty. And then also they have a pacemaker in situ that looks biventricular in nature, with a possibly, I think it's got an AICD in situ as well. And there's something else, another artificial device in there that I'm not exactly sure what it is. Other findings on this chest X-ray is this patient does have cardiomegaly, and the lung fields appear reasonably clear. There's nothing that's really striking out to me, but I don't know
what makes you think. What makes you think it's an AICD?
It's the thick portion to the wire in the sort of the left ventricular portion.
Yeah, great. And I like what you did. You said, look, there's an obvious device here, and you mentioned it's. I think you mentioned it's large. You mentioned the location. So you're telling me true statements. If you were to hazard a guess to what this could be, let's say it is inside the patient and not some kind of tubing on the outside.
No, I've not seen it before.
No, I've never seen a chest X-rays like this as well, but cardiac silhouette markedly enlarged, sternotomy-wise, yes, mitral valve prosthesis. Again, the way you were saying it, you said looks like what is a prosthetic valve, and then you said I think there's mitral valve. So again, true statements up until the point we have to commit to something is a really useful strategy. Looks like an implanted cardiac defibrillator, number of leads 3. There's thickened coil. Maybe it's an AICD if you're not familiar with it, but I like that you're confident that it was an AICD. A large device down there in the lower left chest related to the cardiac silhouette. Is this a cardiac assist device? So that's an LVAD. Yeah, I just wanted to give you a chest X-ray with a whole bunch of things there, just so you can you know what these things might look like if you already haven't had a chance to see these in real life. 6-year-old female, chronic shortness of breath. Describe this chest X-ray. Again, I'll get people 20, 30 seconds to just comment on this. What can you tell me about this chest X-ray?
So the most obvious finding on this chest X-ray is the hyperinflation of the airways. The trachea looks midline. There's no obvious pneumothoraxes. There's blunting of the bilateral costophrenic angles, which could be indicative of an effusion. An elongation of the cardiac silhouette. I can't see any obvious bony abnormalities or any other additional items in the X-ray.
What do you think this is?
I think this could be a patient who has chronic airways disease, like emphysemic changes.
Yeah.
Exacerbation of that. And
so you told me, hyperexpanded chest, there's hyperinflated, you've got flattening of the diaphragm, is all correct. So it really does look like just, chronic airways disease and a lot of hyperinflation here. If at the worst end of this pathology, like say COPD, is there anything else complication-wise you might be able to see that's a relevant negative?
So I guess you could look for infective causes, and then also like bullous changes if she's had a pneumothorax or something.
Great. So what are the infective causes? Absolutely something you look for. Looking for pneumothorax, because she might have bullous changes and something would have burst. So that's not there. How about if another complication of it, pulmonary hypertension? What would you see then, maybe?
I'm not entirely sure.
No, that's all right. We've got marked hyperinflation, flattening of diaphragm, COPD. I'm looking for hyperinflation or bowel chest. If you had the lateral view, you'd see that. And I might look for pulmonary hypertension, so a dilated pulmonary trunk, but there isn't one in this image, which would be out here. And I feel like these are things that we might not have necessarily looked for before, but this is an. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.